Hello, everybody. This is Leila reporting back from day 3 of ACR, our last day of attending session. While we're here live, there still may be some updates coming in the next few weeks where we will be reporting back on some sessions that we may not have been able to watch in person but can watch online. So we're going to be going through all of the sessions to see which ones we potentially would like to still report back on. But today I will be talking about, can lupus be prevented? Can we see who is at risk for developing lupus or RA? And some information about pharmacologic treatments for pain. So let's dive in. The first part is, can lupus be prevented? There is a trial called the SMILE trial. And this is to identify people before lupus fully develops and test if early treatment can prevent or delay disease. And so, with lupus specifically, there's a very stringent or strict criteria to fully get the diagnosis of lupus. Although some of my blood work showed that I had lupus, there weren't all of the criteria that needed to show up to get the official diagnosis. So, for 3 years, I was kind of just waiting to get a diagnosis. And so that happens a lot with people with lupus, that they go a long time and their disease ends up progressing before they get treatment because they don't meet the strict criteria for the lupus diagnosis. And so this trial in particular tests belimumab in people who had antibodies but not full lupus yet. So that can be ANA and double-stranded DNA or C3, C4 complements. Those can show up, or any other autoantibodies. And basically, participants who received belimumab had fewer new antibodies and less immune activation than those on placebo, which suggests immune modulation early on in the disease may help delay lupus onset. And so, the longer that you can go without the full onset, the more that you can prevent severe disease and the more you can prevent any organ damage and things like that. And the more likely you would be to be able to go into remission. And so, this is a new concept of like pre-lupus. They kind of try to compare it to like pre-diabetes, that if you kind of catch it in the early stages, that you can even possibly prevent the onset of it and kind of keep your numbers in that low range. And in the future, maybe we can see if this study can lead us to a way to prevent lupus before it starts. And basically, if someone has a positive ANA or family history, they may be qualified, or see if they could be qualified for early screening or early prevention for lupus. And so that is really cool as we're seeing this come along, because there's so many people that live with AI arthritis diseases that knew that they had symptoms for such a long time beforehand. And just because they weren't able to get the proper diagnosis, they were left with treatment that wasn't really treating the root of the problem. NSAIDs, pain medication, physical therapy, other types of therapy to try to help with the pain and other symptoms, but not getting that early treatment to treat the systemic part of the disease can really be detrimental to the onset and the progression of the disease. And so this is showing that this is really cool that we can possibly see it more early on. And in the same vein, people or doctors are asking, how can doctors tell who with autoantibodies or early symptoms will end up progressing to full-on disease? And this is what they're talking about with lupus, and specifically this part they're going to be talking about a little bit more about RA. And they want to use biomarkers, genetics, and immune patterns to spot high-risk patients. So using biomarkers like autoantibodies, like we were talking about ANA in the last segment, genetics, any genetic mutations that may run in the family, and immune patterns like getting really sick, getting more sick than a normal person might, like with the flu or COVID and things like that, or not being able to fight a disease like that very well. And specifically in lupus, high risk equals multiple autoantibodies, rising interferon levels, and subtle symptoms like fatigue or joint stiffness. So, still seeing in blood serum tests which autoantibodies are present, and still, of course, having that additional joint stiffness or fatigue. And this kind of ties into our auto plus inflammatory arthritis equals X or YZ project. They talk about the subtle symptoms, which are fatigue and joint pain, but that fatigue is considered an auto symptom that we have under this project. Other auto symptoms like this could be rash, especially for lupus, fevers, and things like that, or brain fog. And joint stiffness, joint redness, swelling is the inflammatory arthritis symptoms part, and specifically joint symptoms after long times of rest. So this is putting some merit behind what we're looking at for auto plus inflammatory arthritis equals. And if those symptoms are present, then it gives merit to further testing to see, do they have autoantibodies? Do they have a high CRP? What is going on in the immune system? And not just running a very simple test for testing for one particular disease, but maybe there's a possibility to have more of like a panel that has multiple different biomarkers that can represent multiple different diseases like lupus, RA, axial spondyloarthritis, psoriatic arthritis, and having that all done at once rather than pinpointing one specific disease to test for at a time. And so that's the information about in lupus. And in rheumatoid arthritis, risk often begins years before symptoms. And this is seen with people with anti-CCP antibodies or smoking history. Oh, that's really interesting about smoking history. And trials are now testing whether early anti-inflammatory or lifestyle interventions can stop RA from developing. So it sounds like here that with RA, it can be a lot more environmental factors and lifestyle factors that can be changed in order to possibly prevent or delay onset. So that is super interesting to hear. And when there is family history and maybe any signs of something autoimmune, early testing can really matter. And monitoring, getting those baseline tests can make a big difference to make sure that they catch the disease early. And we suggest for patients to ask, can my lab show if I'm at risk even before diagnosis, and kind of jog that question in your doctor's mind. And it's really tough sometimes when going to primary care doctors, they may not have as much knowledge on what tests to be able to run and all of those types of things. So that's why it can be very helpful for patients or people who may think that they have these diseases to be connected with resources like AiArthritis and other patient organizations to help give them some advice from peer experiences that we've had before. And another plug for our mystery patient guide that is a part of the project of the Auto plus Inflammatory Arthritis equals X or YZ project. That mystery patient guide is chock full of peer advice, peer stories, information about other diagnoses journeys that can help and possibly being able to get that diagnosis earlier. And the future may include preventative care for autoimmune and for autoimmune arthritis. I almost automatically said auto-inflammatory, but auto-inflammatory is not really possible to prevent because it happens right when you're born. But with autoimmune arthritis, it could possibly, in theory, be prevented because there is an environmental trigger that does cause the onset of the disease. And lastly, some updates of pharmacological treatments when it comes to pain. So that means medications and anything else that's prescribed to you. And so one of the main messages that they had in the session was that pain does not always equal inflammation. Some patients have high pain, but low inflammation. And this is a nociplastic pain pattern. And this nociplastic has to do with what's going on in the brain, more neurological, that is causing that pain rather than mechanical or having to do with your joints and inflammation. And so there is a development of a new drug that is called Suzetrigine, and it's one of the first new non-opioid pain drugs that works by blocking pain signals in sensory nerves and may help inflammatory or post-surgical pain. And trials are coming to also see if that helps with neuropathic pain. And there is also another possible option that is called cyclobenzaprine. Specifically, they talk about a sublingual administration, which means like a little tablet that is under your tongue that will dissolve. And this helps to improve sleep and fatigue, which also is shown to be able to help pain in a lot of patients if you're able to help with sleep and fatigue. So that is really cool to hear about, that there may be some more options for these symptoms that our AI arthritis patients deal with on an everyday basis. And specifically, another type of medication, JAK inhibitors, can help pain beyond inflammation in RA and possibly help calming the pathways directly in the brain and nerves when it comes to that nociplastic pain that may be coming from the nervous system. And, the biggest thing is, if pain is such a barrier or a burden in your life, to ask doctors about pain mechanisms and finding words to help describe the pain specifically, because there are different types of pain. There's pain that may come from the nerves or from the brain waves or brain signals, and there's pain that comes directly from mechanical joint use, overuse, and inflammation. So, talking about those types of word that may help describe that pain. If it feels like fire and that's the pain, or if it's a shooting pain, if it's a dull, like long lasting pain, those can all have different origins of where the pain is coming from. And treatment needs to match the type of pain that we're talking about, or else it's not going to work to help calm down the pain. So, whether the pain is coming from inflammation, neuropathic, or nociplastic, it's not just the diagnosis that can determine that. There can be several different factors. And so, I do want to make sure that I read you the definition of nociplastic and neuropathic pain so that I don't butcher it. But so nociplastic pain is a type of chronic pain caused by altered pain processing in the central nervous system, not by tissue damage or nerve lesion. So it's caused by the damage or altering of the pain processing in the brain. And the central nervous system is the brain and the spinal cord. Neuropathic pain is chronic pain condition that results from damage or dysfunction in the nerves and is characterized by persistent burning, tingling, or shooting sensations that can be difficult to manage. And that can be caused by trauma, infections, diabetes, metabolic disorders, autoimmune disorders, or even treatment and medications. So, yeah, that is a little bit more information on the update on pain treatment in our diseases as well. And I hope that you all enjoyed our Go With Us program for ACR 2025, and look forward to having you again for another ACR. And stay tuned to see if there's any more updates on any other sessions that we might be reporting on. Thank you again for coming with us, and we'll see you later. Bye.